All right, let's dive deep into brow lift anatomy and techniques. You know, refreshing our knowledge and maybe picking up some insights that can refine our practice, right?
Sounds good. I'm ready to dissect some brows.
Perfect. So I guess any successful brow lift, we got to start with the anatomy, right?
Absolutely.
The muscles, they shape and move the brow.
We need to understand the origin and insertion,
Yeah.
innervation, action, the aesthetics, how it all works together.
Okay, so let's break down those muscles. Let's start with the ones that create those frown lines.
Okay, so we have the procerus muscle.
Procerus.
Yeah, and it originates from the nasal bones and inserts into the medial brow skin.
Right.
And it pulls the brow down. It contributes to those transverse nasal and glabellar lines that we all see.
Yeah, those pesky lines.
And it's innervated by the temporal and the lower zygomatic branches of the facial nerve.
Okay, got it. And then we have the depressor supercilii.
Yes, the depressor supercilii, which originates from the medial orbital rim and inserts also into the medial brow skin and is also innervated by the zygomatic branches.
Okay.
And this also depresses the brow and deepens those oblique glabellar lines.
So they really work as a pair,
Yes.
creating those frown lines.
Okay.
Now, moving a little bit laterally, we've got the orbicularis oculi. It's kind of multitasker, isn't it?
It is a multitasker. The medial portion, contributes to those oblique and vertical glabellar lines.
Right.
And the lateral part plays a role in lateral brow ptosis. And, those crow's feet.
Yeah.
And it's all controlled by the zygomatic branch of the facial nerve.
So different parts of the muscle creating different issues.
Yes.
And now, I guess, the real star of the show, the frontalis, for brow elevation.
The frontalis.
Yes.
Originates from the gullia, inserts into the brow skin, intertwining with the orbicularis oculi.
Okay.
It lifts those brows, but the downside is you get those horizontal forehead wrinkles with age.
Yeah, that's the trade-off.
Yep. And it's innervated by the temporal branch of the facial nerve.
Right, and those are a common concern for a lot of patients, those transverse forehead lines. But I'm curious about the frontalis muscle. Does it extend, laterally across the entire brow?
That's a good question. It only extends laterally to the temporal fusion line.
Uh-huh.
And beyond that point, there is no frontalis to counteract the downward pull of the other muscles.
Right, so that's why you see that lateral brow ptosis.
Exactly, as we age. More prominent laterally.
That makes sense. Is there anything else we need to think about with the frontalis when we're doing surgery?
Yeah, remember, it has loose connective tissue underneath it, which allows for some movement, but adhesions can develop.
Oh, okay.
And they restrict brow mobility. So surgically releasing these adhesions, can significantly enhance brow elevation.
It's kind of a little bonus
Yeah.
if you release those. Now, I've noticed in some patients almost like an increased frontalis muscle tone. Like it's almost compensating for brow ectosis.
Oh, yeah, definitely. That hypertonicity can counteract the brow ptosis,
Right.
but it can lead to, an unnatural elevation of the medial brow,
Right.
which creates that surprised look.
Right, yeah, I've seen that. So that's something to be aware of when we're thinking about our approach.
Exactly.
Okay, so we talked about the procerus, the depressor supercilii, orbicularis oculi, and the frontalis. Is there any other muscle that we should mention?
Yes, we can't forget the corrugator
Or
supercilii,
the corrugator?
which sits beneath the frontalis. And it actually has two distinct heads, the oblique and the transverse.
Two heads.
Two heads, yes.
Okay, so let's break down the heads.
Okay, so the oblique head originates from the supromedial orbital rim
Okay.
and inserts into the medial eyebrow skin. And again, innervated by the zygomatic branches.
Okay.
And like the procerus and the depressor supercilia contributes to the oblique and vertical glabellar lines,
Pulling the brow down.
pulling the brow down.
Okay, and what about the transverse head?
So the transverse head also originates from the supromedial orbital rim, but this one inserts into the skin above the middle third of the eyebrow,
Okay.
and it pulls the brow medially, deepening those vertical glabellar lines,
Uh-huh.
and it contributes to lateral brow ptosis as well. And interestingly, it's innervated by the temporal branch, unlike the oblique head.
Oh, okay. So much complexity in these little muscles.
It is complex.
It's really important to understand the anatomy, when we're operating in this region.
Absolutely.
So let's shift gears a little bit and talk about the sensory nerves, the ones we don't want to damage.
Absolutely. Preserving sensation is paramount. You damage these nerves, you can have significant complications.
Yeah, for sure. So let's start with the supratrochlear nerve. Where does that one exit the orbit?
So the supratrochlear nerve typically exits through the frontal notch, which is about 17.5 millimeters from the midline, and travels through or deep to the corrugator muscle, emerging about 15 millimeters above the orbital rim, before piercing the frontalis muscle to supply the central forehead.
Okay, and so given its path through the corrugator, I imagine that it's particularly vulnerable during procedures when you're resecting the corrugator.
You are correct. Partial injury during corrugator resection is sometimes difficult to avoid. Thankfully, it's usually of little clinical consequence.
Oh, that's good to know. Now let's talk about the supraorbital nerve,
The supraorbital nerve.
which plays a really big role in the sensation of the forehead.
It does, and it exits a bit more laterally, typically through the suborbital foramen or notch, which is about 25 millimeters from the midline. And then it branches into a superficial and deep branch.
Okay, two branches.
Right.
And what areas do those branches supply?
So the superficial branch pierces the frontalis muscle, runs above it, supplying the forehead up to about 2 centimeters behind the hairline. But the deep branch, that's the one we need to be careful of. It runs laterally within the deep galeal plane, about 1.5 centimeters medial to the temporal crest, and supplies the scalp all the way up to the vertex.
Oh, wow. So that deep branch has a much more extensive territory.
It does.
So I imagine that puts it more at risk during surgery.
It does, yeah, especially those procedures with the coronal incisions and subgaleal dissection, transecting this deep branch. That's often the cause of those post-operative scalp paresthesias that patients get.
Yeah, so understanding that anatomy can really help us avoid those complications.
Absolutely.
All right. So are there any other anatomical landmarks that we should be aware of when we're operating in this region?
Yeah, the sentinel vein is an important one.
The sentinel vein.
Yeah, particularly when we're working in the temporal region.
Okay, can you tell me a little more about that, like the location and significance of it?
Okay, so the sentinel vein, it's the more medial of the two zygomaticotemporal communicating veins, and it acts as a bridge between the superficial and the deep venous systems.
Okay.
And it runs from the temporalis muscle through the fascia and into the subcutaneous tissue. It's a valuable landmark because it sits just below the lowest branch of the temporal branch of the facial nerve.
Okay. So if you can identify that vein,
Yeah,
then you know where that temporal branch of the facial nerve is.
exactly, and you can protect it.
Protected during surgery.
Yeah.
So is there a reliable way to find this sentinel vein?
Yeah, so it's typically found about 1.5 centimeters above and lateral to the lateral canthus.
Yep.
Or another technique, you draw two lines, one from the supraorbital notch to where the zygoma meets the helix, and another from the mental foramen to where the zygoma meets the lateral orbital rim. And that sentinel vein, it usually lies within 4 to 9 millimeters of where those lines intersect.
Oh, that's a good tip.
Yeah.
Okay, so that's the sentinel vein. And what about the supraorbital rim?
So the supraorbital rim, it's another important structure to consider, especially when evaluating brow ptosis. It's typically more prominent in men. And interestingly, the supraremedial portion, it tends to resorb with age, contributing to the brow descent.
Oh, okay. So those age-related bony changes also play a role.
They do.
Now let's get into the motor nerves, the ones that really move the brow.
The temporal branches of the facial nerve.
Yeah.
So these run within the temporoparietal fascia, right on top of the periosteum over the middle third of the zygomatic arch.
Okay.
And at a point about 1.5 to 3 centimeters above the zygoma and about 1 centimeter behind the lateral orbital rim, they transition to run just beneath the superficial temporal fascia.
Okay.
So this transition zone, it's a critical area to be mindful of during surgery.
You don't want to injure them there.
You don't know.
Anything else about their course that's important?
Yeah, they pass about 1.5 centimeters lateral to the lateral edge of the eyebrow. And, keeping this in mind is crucial when we're planning our incisions and our dissection plane.
Right, to avoid those branches. Now let's talk about the brow retaining ligaments. How do those play a role?
Yeah, so the brow retaining ligaments, they're essential for maintaining brow position. One key ligament is the orbital ligament, which is a fibrous band that connects the orbital rim to the superficial temporal fascia deep to the lateral eyebrow.
Okay.
And then there's also the temporal and the supraorbital ligamentous adhesions, along with the thickening of the periorbital septum laterally
Okay.
that can restrict brow movement.
So these were all things that need to be released
They do to achieve that brow elevation.
during a brow lift.
Yes, and we can't forget about the brow retaining ligament and the upper lid retaining ligament. These are zones of attachment from the bone to the overlying skin that also need to be addressed for successful brow elevation.
So it's pretty complex, the ligaments and the muscles all working together to keep that brow where it is. Now, I want to transition to the aesthetics of the brow. I know there's no one-size-fits-all because Ideal brow characteristics are different based on gender and ethnicity. But are there any general guidelines?
You're right, individual variation is key. But there are some general aesthetic measurements that can help us get to that, balanced and harmonious result. So for example, the medial brow should ideally be positioned on the supraorbital rim, vertically aligned with the alar base and medial orbital fissure.
Okay, so really anchored to those bony landmarks.
Yeah.
And what about the lateral brow?
So the ideal lateral brow position, it differs between men and women. In men, it should rest on the orbital rim at the level of the lateral limbus. However, in women, it can be positioned a bit higher, up to 1 centimeter above the orbital rim.
So a little bit more of an arch
Yes.
for women. And what about the overall shape of the brow, like the ideal arch?
A gentle arch, with the peak at the junction of the medial 2/3 and lateral 1/3 of the eyebrow. And this peak should lie at least at the level of the lateral limbus of the iris.
All right, so those are good guidelines. Any specific measurements we should keep in mind when we're looking at brow position?
Yes, there are several key distances. So in the midpupillary line, the ideal distance from the anterior hairline to the brow is about 5 to 6 centimeters.
Okay.
From the brow to the superior orbital rim, 0 to 1 centimeter. The distance from the brow to the supratarsal crease should be around 1.6 centimeters. And from the brow to the midpupil, about 2.5 centimeters.
All right, so those are good measurements to keep in mind when we're evaluating our patients. Now let's talk about those changes that we see in the aging brow. What contributes to that aged appearance?
So as we age, we see a constellation of changes. The formation of wrinkles, those transverse forehead lines, oblique and vertical glabellar lines, brow orthosis, the degree of frontal bone convexity. The prominence of the supraorbital rim also comes into play. The height of the forehead, the amount of retroorbicularis fat, even the hairline position and hair thickness.
So it's multifactorial.
It is.
It's not just wrinkles and drooping.
Oh, it's everything.
Yeah, so it's important to keep all these factors in mind. When we're thinking about surgery for the brow.
Absolutely.
Okay, let's get into the surgical techniques, the techniques that we have to address these changes.
Yeah, that's where things get exciting.
Yeah.
There's a whole spectrum of techniques, each with their advantages and disadvantages. And the choice depends on a multitude of factors: the patient's anatomy, the extent of brow ptosis, their hairline, hair thickness, and of course their goals.
So it's really individualized.
It is, yeah.
Okay, can you walk us through some of the approaches?
Yeah, so let's start with the classic coronal brow lift, which involves an incision across the top of the head, behind the hairline. It provides extensive access for, correction, but has become less popular due to the invasiveness and the, less invasive techniques that are out there.
Right, I've noticed that as well.
Yeah.
But are there still situations where a coronal brow lift is preferred?
Yeah, patients with a low hairline, it allows for, camouflaging of the scar.
Right, it makes sense. So what about the patients with a high hairline?
So in those cases, an anterior hairline incision can be a good choice. So the incision is made just behind the hairline. And it can be designed, in a zigzag pattern to help minimize the scar. But there's always a risk, of course, that it's going to be visible, especially from the front.
Right. And are there any other, tips to minimize scar visibility?
Yeah, for men experiencing hair loss, best to place the incision further back to make it less conspicuous. And generally, we remove more scalp laterally than medially, to address that typical pattern of lateral brow descent.
Those are great tips. Now, what about the endoscopic brow lift, which is becoming so popular?
The endoscopic brow lift.
Yeah, it's minimally invasive.
It is, yes. It involves several small incisions hidden within the hair, allowing us to insert an endoscope and specialized instruments to elevate the brow. And the advantages are significant over the open approaches. Less scarring, quicker recovery, reduced risk of numbness. However, it requires, meticulous release of the periorbital septa and adhesions to achieve that optimal brow elevation.
So really precise technique.
Yes.
Now, are there any other techniques we should know about?
Yeah, so the temporal approach. The incision is placed over the temporalis muscle.
Okay.
And dissection proceeds just above the deep temporal fascia to protect the temporal branch of the facial nerve. And it's, less extensive than the coronal approach, while avoiding that incision across the top of the head.
Right. So a good balance between access and minimizing the invasiveness.
Yes.
Now, I know a lot of times we combine techniques.
Yes.
Especially with periorbital rejuvenation.
Yeah, absolutely.
Can you talk a little bit more about those combination approaches?
Yeah, so, a brow lift can be combined with upper and or lower blepharoplasty. to address both the brow ptosis and the eyelid aging.
Right, so you're really getting a more,
Harmonious and comprehensive result.
yeah. And are there any specific combination approaches that stand out?
One effective combination is using the temporal approach along with transpalpebral incisions.
Okay.
And, this can provide results comparable to the coronal approach, but, minimize the scarring. We can also perform a transpalpharoplasty brow lift, where the brow is fixated to the periosteum or deep temporal fascia. Through an upper eyelid incision, this technique provides a mild lateral lift, and it helps stabilize the brow position.
So you can actually get some brow elevation
Yeah,
through the eyelid incision.
you can, yeah.
That's interesting. Now, what about the direct brow lift approaches, the suprabrow and the midbrow?
So these techniques involve removing a strip of skin directly above or near the eyebrow, and, they're particularly useful in specific patient populations.
Okay, so when might we choose those?
So the superbrow technique is particularly well suited for men with thick skin, deep wrinkles, because you can hide the scar in the eyebrow. It's also good for patients with androgenic alopecia, as it avoids incisions where hair loss is occurring.
Okay.
And additionally, beneficial for patients with facial paralysis who have deep wrinkles.
So it's addressing very specific
Anatomy,
issues.
yes.
Okay, what about the midbrow?
So the midbrow technique is, similar, but it uses an incision that's placed in a transverse wrinkle in the mid-forehead, so you can conceal the scar. And like the superbrow lift, it's, often preferred for men with thick skin, deep wrinkles, and hair loss. And, an added benefit is it helps advance the hairline downward.
Ah,
Yeah.
okay. So interesting approaches. Now, I've heard that the distance between the incision and the brow can influence how much skin you have to remove
It does, yeah.
to get that brow lift.
So generally, the farther the incision is from the brow, the more skin needs to be removed for the same amount of brow elevation.
Okay, that makes sense. So something to keep in mind when you're planning.
Absolutely.
All right, let's talk about the different dissection planes.
The dissection planes.
Yeah.
Yeah, so the choice of dissection plane is crucial, and it can significantly impact the effectiveness and the safety of the procedure. So the three main options are subcutaneous, subgaleal, and superiosteal.
Okay, let's go through those. Starting with the subcutaneous plane, what are the advantages and disadvantages there?
So the subcutaneous plane, it's, dissecting just beneath the skin. And it has some key advantages. It preserves the sensation of the posterior scalp, by avoiding the deep branch of the supraorbital nerve. And it allows for the release of dermal adhesions, which, can improve deep transverse wrinkles. However, it disrupts the blood supply to the skin flap, so potentially increasing the risk of wound complications.
So there's that trade-off.
And it makes it more challenging to perform myectomies of the brow depressor muscles.
Okay, so you get the wrinkle improvement.
Yeah.
But you have a little higher risk of wound healing issues.
That's right.
Now, what about the subgaleal plane?
So the subgaleal plane involves dissecting beneath the galea aponeurotica, that tough fibrous layer that covers the skull. And this plane allows for, a faster and easier dissection compared to the subcutaneous plane. And it provides direct access for muscle excision or scoring.
All right, sounds more efficient.
It is.
Okay, and now the superiosteal plane.
The superiosteal plane. So in this plane, we dissect directly beneath the periosteum, the membrane that covers the bone. And, this approach, it requires release of the arcus marginalis, that fibrous band along the suborbital rim, to get brow elevation. However, it's important to avoid superiosteal dissection in the medial brow area if medial brow elevation is not desired.
Okay, that's good to keep in mind. So it sounds like each plan has its own set of considerations.
It does.
Is there a consensus on which one gives the most durable result?
There is some debate on whether subgaleal or superiosteal lifts provide more long-lasting results. Some believe superiosteal lifts are more durable because, you're anchoring that brow more securely to the bone. Others argue that subgaleal lifts are equally effective and, may even have fewer complications.
So I guess the jury's still out?
It is, yeah.
Now, I've heard the term biplanar approach.
Biplanar approach.
What is that?
So this combines the benefits of both subcutaneous and endoscopic superiosteal techniques.
Oh, okay.
So it involves subcutaneous dissection to address those forehead wrinkles and endoscopic superiosteal dissection for the brow elevation. So you're getting, a more comprehensive approach.
Yeah, to brow rejuvenation.
Absolutely.
All right, that makes sense. Now let's get into muscle weakening.
Muscle weakening.
Yeah,
Yeah, so weakening those brow depressor muscles, it's a key component to achieving a natural-looking brow lift.
right. We want to relax that downward pull
We do.
and soften those frown lines. So what techniques do we have?
So one common technique is direct muscle excision, where we surgically remove portions of the corrugator and sometimes the frontalis muscles.
Okay. Any specific considerations when you're doing direct muscle excision?
Yeah, so preserving at least 2 centimeters of the superbrow frontalis, that's crucial to maintain, brow animation.
Huh.
And, we often graft the glabella with fat after removing the corrugators to, address any contour deformities that might result from, removing that muscle bulk.
So you're not just removing muscle, you're also thinking about
Replace area.
the volume
Replacing the volume, yes.
and contour.
Absolutely.
Okay, so that's direct muscle excision. What are some other techniques for weakening?
So another option is muscle scoring, where we make, small incisions or scores in the muscles to weaken them without completely removing them. So this can be applied to the frontalis, the corrugators, even the lateral orbicularis oculi muscles. So scoring the lateral orbicularis can actually help with brow fixation by reducing its downward pull.
Okay, so it's a little less aggressive
It is, yes.
than excision. Now, what about botulinum toxin? What role does that play in brow lift surgery?
So botulinum toxin, it's a valuable adjunct for, achieving brow elevation. It temporarily paralyzes those muscles that are pulling the brow down, smoothing out the wrinkles, and, allowing the brow to lift. And it's particularly useful in patients with facial paralysis to help achieve that brow symmetry.
So it can be used as a standalone or as an adjunct to surgery.
Absolutely.
All right, now let's talk about securing that brow.
Securing the brow.
Yeah, once we've done the dissection and the muscle weakening,
Yeah.
what do we need to think about to keep that brow up?
So the fundamental principle is the elastic band principle.
Okay.
The farther the suspension point is from the brow, the less effective the lift will be.
So you want to make sure that you anchor it well
Exactly.
to maintain that elevation. All right, so how do we actually achieve that secure fixation?
Okay, so in open techniques like the coronal or anterior hairline approaches, skin excision is used to elevate and secure the brow. And the ratio of skin excision to brow elevation, is typically at least 2.1 for coronal brow lifts.
2.1.
Yeah, so for every 1 millimeter of brow elevation, you need to remove at least 2 millimeters of skin.
Okay.
This ratio is lower for superbrow or mid-forehead approaches. Initially, around 1.1,
Oh.
but we need to account for about 50% relapse in the long term.
Okay, so that's for open techniques. And what about for endoscopic brow lift?
So in endoscopic brow lifts, suture techniques are used. One popular method is the cortical tunnel technique, where a suture is anchored to a tunnel created in the outer table of the skull. Another option is using, lateral spanning suspension sutures, which, provide a more broad and secure fixation.
Right, so those are suture techniques. Are there any other options?
Yeah, we can also use devices to secure the brow, like screws with or without attached sutures, K-wires, barbed securing devices, and bone anchor devices.
Wow, lots of options.
Yeah, and they offer varying degrees of fixation strength.
Yeah.
And, can be chosen based on the needs of the patient and, of course, the surgeon's preference.
Right. All right, well, I think this has been a great overview
Yeah.
of brow lift anatomy and techniques.
It has.
But I know we still have more to discuss. So why don't we take a quick break, and we'll come back and pick up the conversation in part 2 of our deep dive.
Sounds good. Okay. So, when we talk about the stigmata of forehead aging, we're looking at several factors. Of course, there's the wrinkles, the transverse forehead lines, the oblique and vertical globular lines. But we also need to consider the brow ptosis itself, the convexity of the frontal bone, the prominence of the supraorbital rim, the height of the forehead, the amount of retroorbicularis fat, or ROOF, which is the fat pad deep to the orbicularis oculi muscle. And even the hairline position and hair thickness can, play a role.
So it's really like analyzing all these different pieces and how
It's-
they all fit together.
It's a puzzle.
Yeah, so how do we approach these different components surgically?
Well, so for dynamic wrinkles, the ones that appear with facial animation, botulinum toxin injections can be very effective. It temporarily paralyzes the underlying muscles, smoothing out the wrinkles. And surgically, we can achieve more lasting results by weakening those muscles.
What about static wrinkles, the ones that are there all the time?
So static wrinkles, they require a more comprehensive approach. And while surgical muscle weakening can help, it often needs to be combined with, soft tissue redraping to really address those deeper set-in wrinkles.
Right, so you have to address the muscle and the skin.
Yes.
Are there any non-surgical options for those wrinkles?
Absolutely. So fillers and resurfacing procedures like laser treatments or chemical peels can be effective for, more superficial wrinkles. They can improve skin texture and tone,
So it's all about,
enhancing that rejuvenation.
yeah, adding those extra little...
Absolutely.
Okay, so I think it'd be helpful to go back to the dissection planes and
Uh-huh.
talk about kind of, the technical aspects and how we choose which plane
Sure.
for each patient.
So the subcutaneous plane, dissecting just beneath the skin, it's often preferred when we want to release those dermal adhesions and really address the deep wrinkles. But, as we mentioned, it can compromise the blood supply to the skin flap. So we have to weigh that risk against the benefit.
That's a subgalar plane. Yeah.
Subgaleal plane, dissecting beneath the galea. It's a good option when we need quick and easy access to the muscles for excision or scoring. It's also a relatively avascular plane, which can minimize bleeding.
Okay, and the superior steel plane.
So the superiosteal plane, dissecting beneath the periosteum. This provides the most secure fixation for brow elevation. But it does require release of the arcus marginalis and, can be a little bit more technically challenging. We need to be careful to avoid dissecting superiosteally in the medial brow area if medial brow elevation isn't desired.
Okay, so it really depends on the goals and the patient. Now, let's go back to the muscle weakening techniques.
Yeah.
We talked about direct muscle excision and muscle scoring.
Yes.
Can you talk a little bit more about those?
Yeah, so direct muscle excision, it involves removing a portion of the muscle, usually the corrugator supercilia, and, this can effectively weaken the muscle and reduce that downward pull on the brow. But it's essential to avoid excessive excision, particularly in the medial brow, to maintain that natural brow movement.
Right, so you don't want to over-resect.
No.
What about muscle storing?
So muscle scoring involves making, small incisions or scores in the muscle and essentially weakening it without completely removing it. It can be a less aggressive option
Okay.
and maybe preferable in some cases. And this can be applied to the frontalis, the corrugators, even the lateral orbicularis oculi.
I've heard that scoring the lateral orbicularis can help with brow fixation.
That's right. By scoring it, we can reduce the downward pull, which indirectly contributes to brow elevation.
Okay, good to know. So now let's move on to securing the brow
Securing the brow.
in its elevated position.
Yeah, so securing the brow effectively, it's crucial for achieving those lasting results. And, in open techniques, skin excision is the primary method, and we need to accurately calculate the amount of skin to remove to achieve that desired brow elevation. And remember, that ratio of skin excision to brow elevation, it varies depending on the approach. It's generally higher for the coronal brow lift than for the super brow or mid-forehead approaches.
So those ratios are really important to keep in mind
Yeah.
for surgical planning. And then for endoscopic brow lift, what are the techniques there?
So for endoscopic brow lift, we rely on sutures or specialized devices. So sutures can be anchored to the bone using the cortical tunnel technique, or we can use lateral spanning suspension sutures
Yeah.
for that broader fixation.
And then for devices.
So for devices, we have a variety of options: screws, K-wires, barbed securing devices, bone anchor devices. Each device offers, different advantages in terms of fixation strength and stability. And, the choice depends on the specific needs of the patient and, the surgeon's experience.
Right, so lots of tools
Lots of tools.
to help us secure that brow. Now, I think it's important to talk about complications.
Complications.
Yeah, because no procedure is completely risk-free.
That's right.
So how can we minimize those risks?
So one of the most common complications is hematoma formation. And, careful hemostasis during surgery is crucial. We use a combination of techniques: electrocautery, bipolar coagulation, topical hemostatic agents, to control that bleeding.
And infection.
So for infection, we follow, strict sterile techniques,
Right.
proper surgical prep, sterile instruments and drapes, wearing appropriate attire. We might also prescribe prophylactic antibiotics.
Okay, and nerve injury.
Nerve injury.
We talk about the sensory nerves.
Yeah, so the temporal branch of the facial nerve, that's the main motor nerve that we need to be aware of. And, as we discussed, it's vulnerable in that temporal region, where it transitions from running on top of the periosteum to running beneath the superficial temporal fascia.
Right, so be very careful in that area.
Very careful.
Alopecia hair loss.
Yeah. So careful incision placement is crucial, especially when working near the hairline. We also avoid excessive tension on the scalp during closure, which can damage the hair follicles.
Are there any other things we can do specifically during surgery?
Yeah, so using a, lower temperature cautery setting can help minimize that thermal injury. And, we try to avoid unnecessary manipulation or trauma to the scalp tissues.
So gentle handling.
Gentle handling, yeah.
Okay, and overcorrection.
Overcorrection.
Yeah.
So overcorrection is a concern. And it often stems from removing too much skin or placing the brow too high. So careful preoperative planning, taking accurate measurements, having a clear understanding of the patient's goals, that's essential.
And if overcorrection does happen, how do we address that?
So in some cases, minor overcorrection can improve over time as the tissues settle. But if it persists, we might consider using neuromodulators to relax the frontalis muscle and lower the brow slightly. But in more severe cases, revision surgery might be necessary.
Okay, good to know. Now let's touch on asymmetry.
Asymmetry.
How do we make sure that we get nice symmetry in the brow?
So achieving symmetry is crucial for a natural-looking result. We carefully assess the brow preoperatively, taking measurements, comparing the two sides. And during surgery, we use a meticulous technique to ensure that we're lifting and securing the brows evenly.
And are there other factors that contribute to asymmetry?
So unequal muscle weakening can also lead to asymmetry. So, we need to ensure that we're weakening the muscles on both sides equally to achieve that balanced brow movement.
Now, before we move on, I want to talk about patient communication.
Patient communication.
Yeah, which I think is so important for a good outcome.
Absolutely. Open and honest communication with our patients. It's essential for ensuring their satisfaction and managing their expectations.
So can you give us some examples of how we might, tailor the approach based on the patient?
Sure. So let's say we have a patient with a low hairline and significant burpitosis. A coronal brow lift might be a good choice because it provides the most extensive access and allows us to address both the brow and the forehead.
Right.
However, if the patient has a high hairline and is concerned about a scar, we might choose an endoscopic brow lift or a temporal approach, which offer less scarring but might not provide as much lift.
Right. So it really depends on the patient.
It does.
What about patients who aren't ready for surgery?
Yeah, so for those patients, neuromodulators like botulinum toxin can be a great option, achieving brow elevation, smoothing out those wrinkles, particularly in patients with mild to moderate brow ptosis. Fillers can also be used to restore volume and improve brow contour.
So, it's good to have those non-surgical options as well.
Yes.
So that we can meet the needs of all our patients. We've covered so much, from anatomy to surgical techniques to patient communication.
We have.
The role of technology, it's all been covered.
It's been a pleasure.
A big thank you to you for sharing your expertise and insights.
You're welcome.
And to our listeners, thank you for joining us. We hope you found it valuable, and that it will help you refine your skills and deliver even better outcomes for your patients. So keep learning, keep innovating, and keep striving for excellence.